thinking about why this happened, I found eventually that it was being cleared by macrophages in the spleen. And you can see it in macrophages in the spleen, you can see it in macrophages in the lung. So it's probably complement mediated. The complement coats the virus, which is then able to be taken up and phagocytosed. So then what I did is to basically inhibit these, to prove it, you inhibit the macrophage function, which is something called collagenate liposomes. You inhibit it and you get exactly the same function as you did before. So you give it intravenously, and now you can see it in the tumours, and that's great, but you're not really going to want to immunosuppress a patient who's got cancer. It's not a very good idea.
But the vaccine virus you're using is not adapted to mice though, right?
Yeah, so the reason you can use it and investigate it in other mammals is because it's able to replicate in most mammals, most mammalian cells. And I'll talk about that in a minute. So mice is a reasonable model to use, but a better model to use is the hamster, which I'll tell you why. So I thought, okay, so the key is the immune response. The immune response is clearing all this virus, so we need to address that in some way. And I heard a talk, this was about 3 years ago. I heard a really interesting talk, someone was talking about malaria. Malaria is obviously a huge problem. Why isn't there a vaccine to malaria that works well? Because the epitopes aren't very immunogenic, and it's able to conceal itself within cells once you're infected. So lots of different ways have been used to try and boost the immune response to some part of malaria. And one method that this guy used, so he used adenovirus and he used vaccinia-virus. He used adenovirus and vaccinia-virus, and they inserted a couple of genes from the cell from the outer layer of Plasmodium falciparum. Inserted those into these viruses, so that then the virus would express these malaria genes, if you like, and try and create a vaccine to the malaria from that. So am I explaining that well? Why do they use adenovirus and vaccinia-virus? Because in virology, just with any type of vaccine, it works better if you have a prime and then a boost. And you can do that in all different number of ways. And one way of doing it is by using a different virus as a prime and a boost. That's what they do. So I thought, well, why not try the same thing with oncolytic viruses for cancer? Problem was, there's no model to do it. So I had to develop a whole new model. This was in collaboration with some guys in China. So we used a hamster, because the hamster is the only animal that adenovirus and vaccinia-virus replicates in the tumour cells. And everyone knew adenovirus did, but no one had done any work with vaccinia-virus. So I had to prove that actually it was a sensible model, that the viruses replicate in it, that they express the viral transgenes, and so I did all that. So that's all fine. And then, interestingly, tried this sort of prime boost regime. So what you did is take animals. You take hamsters. The hamsters have got hamster tumours, and you inject the tumours with adenovirus, and then you inject them with vaccinia-virus. Or you try the reverse, or you try just one virus or the other virus as a control, or nothing. Okay, so what happens? I was pretty surprised. What happened was that the animals that you don't treat at all, the tumours continue to grow, and they die. The animals treated with just adenovirus continue to grow, same with vaccinia-virus, and they die. Those treated with adenovirus and vaccinia-virus do way better, and about 2/3 of the animals were cured, which was really surprising, and most of them are alive a few months later. And this the same in two different tumour types, two different models, and that was really, really surprising. So I wanted to find out, why does this happen? What's behind this? The first thing was just looking at the tumour. So this is just if you look at the top ones, it's pretty difficult to see, but this is just H&E staining, and you can see that if you look at the number of lymphocytes, so the little dark dots, there's a lot more of them in the ones treated with adenovirus, with the tumours that have been treated with adenovirus and vaccinia-virus. So there's a lot more lymphocyte infiltration, which gives you an indication that there's a host immune response to the tumour. Can't tell what that is, but it gives you an indication. And apoptosis is higher as well, so there's something that's causing tumour death, cell death. And even more surprisingly, so you take these animals that have been cured if you like, for a few months, not very long, and then you give them another dose of tumour. So you inject them with some more of the same tumour cells. Okay? So these animals you inject with the same tumour cells as they've had before, and they don't grow any tumours. You inject them with a different type of tumour cell, and they grow, which means that you've created an immunity to that tumour which you'd treated before.
How did you initially get the tumour?
Yeah, so initially what you do is just inject it subcutaneously. I did the squamous cell carcinoma, I did either into the floor of the mouth, and you do it with vestibular schwannoma as well, but anyway.
They're like tumor lines from hamsters?
Yeah, so they're hamsters that have tumours. Hamsters have had hamster tumours. All animals get cancer. And they've been actually collected by scientists, and then those tumour cell lines have been immortalised and grown, and you can buy them. So, and there's not many available for hamsters. Lots for mice, but not so many for others. So, yeah, I'll just leave it at that, I think. Anyway, so I wondered, what's happening? What's causing this? It's most likely to be a host immune response to the tumours, and you're getting then long-term immunity, which means there's some kind of memory T cell there. It's likely to be a T cell dependent response, unlikely to be antibody dependent. And so I looked at the antibody levels, and it was just the same in all of these animals. If you looked at then, the problem was, so you want to, if you want to prove that something's due to a particular cell type, you need to get rid of it. So that's usually reasonably easy because you can give an antibody to it. Problem was, it was a new type of model. They're not available, so we had to develop a new antibody as well, which took ages. So we developed an antibody to CD3, which is expressed on T cells. You give that to the animals, and animals with these hamster tumours, treated with nothing, tumours grow, they die. You treat them with just adenovirus or vaccinia virus. We know, with adenovirus and vaccinia virus, well, they do really well. We know that already. However, if you inhibit the T cells, which are these ones here, then the tumours continue to grow. So it must be a T cell response. I don't know anything more than that. It takes a long time to develop antibodies and to develop the tools to do this, but that's what I thought was happening, and that appears to be what's happening. So this is interesting because what we're doing is creating a prime, so using oncolytic viruses, but using them to not only for their oncolytic properties, but using them as a vaccine. Why does it work? We don't really know. Probably because adenovirus activates toll-like receptors. They improve antigen presentation, which means you get a greater take of tumour-associated antigens to start with. The boost in vaccinia virus, probably because they create a very vigorous host immune response. They have lots of immunoregulatory proteins, which are not very well understood, but that's probably what's causing it. I don't know. But anyway, this technique, if you like, they're trying to patent it, but they can't because it's not possible to patent something like this, apparently. So anyway, that's sort of now the continuing work I'm doing is looking into the mechanism as why this is happening, so then we can improve the regime. So this is really promising. So then it comes to now what we're going to do in the future. Well, continuing with this, but now we come to other type of skull-based tumours. So as I've said, go on.
Because it's related to your previous, before moving on to the other one, are you able to find out what T cell is clonally expanding, what antigen they're actually responding to?
Yeah. So that's what we're doing at the moment. But you have to create the antibodies to look at it first, which is what we're doing. It's not that straightforward.
So for instance, you couldn't...
I can't just take out the CD4 and CD8, the TL.
Sort for lymphocytes, even look at the VDJ, away or look at whatever's on the T cell for?
No,
You can't do that.
because you got to create the antibodies to help you to be able to do that to start with.
Because I figure once you find out what that is, then once the infection is well underway, you could give a boost with a adjuvant, something to stimulate
Yeah, I mean,
further immune reactions.
to be honest, I mean, it's amazing this works so well because it's only, it's just a monotherapy really. And, most effective treatments, especially for advanced tumours, other than, early tumours treated with monotherapy, advanced tumours treated with multimodality treatment therapy, and these are very well tolerated as well. So this is where it's going to be interesting in the future, combining it with other treatments. Not on their own, I wouldn't envisage that at all. Okay, so let's go on to, briefly on to other skull-based tumours. So VEGF, vascular endothelial growth factor, is overexpressed in lots of different benign skull-based tumours. I've said angiogenesis, the vessel density is proportional to the rate of growth in these tumours as well. And this is all the patients we've got in Cambridge. So the NF2 patients, they have a very poor prognosis because they have lots of different types of benign tumours, both intracranial and extracranial. And we look at the patients between sort of 15 and 40 years, and that's where a lot of them die. So this is a disease I'm interested in because it has, even though they're benign tumours, it has a very poor prognosis, and it was because of this paper that again I've become more interested. So this is again in Harvard. They've used bevacizumab, so that's a monoclonal antibody, which is an angiogenesis inhibitor, and they've used that in patients with vestibular schwannomas, in NF2 patients where they've got huge tumours which aren't very amenable to surgery for whatever reason, and so they tried an angiogenesis inhibitor, and the results were pretty impressive. Even better than that, it's had some hearing improvement. This is only in a few patients. It was only about 12 patients. So on the back of this, I started using it for the last year and a half in the UK, and using it here now as well. And we've got very strict indications for using it, which is basically patients who either got very, very rapidly growing tumours or they don't want surgery for whatever reason. And doing it as part of a national trial. And the results so far have been pretty good. The problem is you're only stopping the tumour growth. You're stopping the tumour growth, maybe shrinking it a bit, and that's fine with these tumours. It probably doesn't matter. But you're going to have to give it long term. And long term means toxicity, means probably resistance. So you don't know how long we need to use these type of treatments for. And so I'm interested in looking at trying to identify which patients this is going to be useful for and how we're going to monitor it. So a couple of things that I've been working on here, again, this is what I want to do is set up things that are going to be long-term and long-term collaborations, and Dr. Sumru there's a bispecific antibody which we're going to try in an animal model of these patients. Bispecific means it's an antibody to two different molecules. And also, so there's different ways of imaging these patients, and dynamic contrast enhanced MRI is a good way of looking at angiogenesis. There's lots of different methods that have been used. The problem is you've got relatively small tumours in vestibular schwannomas. They grow slowly. They're all pretty vascular, so how do you tell the difference between them? And this method, I think, is going to be the most useful. It's been used in other tumours, hepatocellular carcinoma most commonly. And it's very simple. You basically give a bolus of contrast, and instead of just taking an image, a contrast-enhanced image 30 seconds later, you take images every few seconds. You look at that area of the tumour, and you look at the signal uptake, the density, and you monitor that over time. So you get effectively like a bell-shaped curve, which is the contrast inflow and washout. And then you can do calculations from that, which tell you what the likely rate of angiogenesis is, so it's all relative. So I think this is a way you're going to be able to monitor these tumours and even be able to predict the ones that are going to grow, the ones that aren't going to grow. And it's a technique that's been used here, so I've been working with Nancy Fishbein and Greg Zacharuk here, and to try and change the protocol they've got so it can be used for skull-based tumours. I'm also doing this in the UK as well. So this is again something we set up for long-term collaboration. So what's going to be interesting in the future, for me anyway? I think use of angiogenesis inhibitors now it's already commonplace use for malignant tumours. I think there's opportunities with benign tumours, especially the skull-based, because of the morbidity of the surgery that's involved, which is why I think it's important to explore other types of therapeutic options as well. And again, if you can stop the tumour growing, that's fine. You don't need to shrink it most of the time. So I think there's lots of opportunities for that. Also, so oncolytic viruses have been used in vestibular schwannomas. They've been used in glomus tumours, but I think the work that's been done isn't really that very good. So I want to sort of carry this on back home, and I set up a tumour bank, so we were collecting all these types of benign tumours as well for the last couple of years. And so really it's just, it's an open thing that if anyone's interested in this and wants to be involved in long term, I really want to set up sort of long term collaborations between Stanford and when I go back to Cambridge, which would be really interesting for the future. So these are a few of the people who've done some of this. I've done some of this work with, both back in London, and it's really nice being collaborating with people with different places, both here and in China. So thank you for listening. Any questions?
In the 2 virus model that you have, do you think that the effect that you're seeing, is it, you kind of alluded to it a little bit, you think it's an adjuvant effect of having a bigger antigen load in the mice, or do you think it's really a replication effect in tumor itself?
Yeah, I think it's not. I think the replication of the virus is probably secondary. So the fact that you're inducing effectively long-term immunity somehow, most likely through tumour vaccination. And the thing is, if you use a non-replicating virus, you have a very low viral load. Whereas if you have a replicating virus, which is able to replicate specifically within the tumours, then you're creating that vaccine inside you to the tumour specifically. And that's what's exciting.
Did you use some of your luciferase tumors in the hamster model as well, or to see that it's replicating inside the tumors?
Yes, done that as well. It does.
It does.
And you can look with immunohistochemistry as well, look at different organs and toxicity.
And is it as robust as it is in the skid mice, or is it kind of in between where it's more diffuse but it does prefer the tumor cells?
It's pretty specific.
It's pretty specific.
It's better than just one on its own.
What are the long-term detrimental effects, aside from financial, from using bevacizumab?
So
it's got to be an astronomical cost.
Yeah, the cost is huge. It's very expensive. That's why I think at the moment, like with any, it's not a new drug, with any new indication. For example, with NF2, with vestibular schwannomas. It's sort of used for anyone where they have an aggressive tumour. You don't know which ones are going to respond. And exactly because of that reason, because of the toxicity that these patients do get from using it for maybe longer than a few months, I think you need to be able to try and find a way to choose the correct patients, which is why I think imaging to detect those tumours that have the highest level of angiogenesis is probably a sensible way of doing it.
What are the other toxicities, James, associated with that?
Yeah, so it's rashes, skin toxicity, renal toxicity, one thing they thought wouldn't happen, which is resistance or tolerance, probably does actually happen. Probably does. But we don't know why. We don't know if this is going to be effective long term, even though it's such a specific monoclonal antibody. And I don't know the mechanism behind it.
I guess the reason I ask is, I'm not sure if you're familiar with Terry Davidson's work in treating patients with hereditary mitochondrial contagion. Angiogenesis. Are you familiar with that?
Not very.
I'm not very familiar with it either, except that obviously it's going to be a long-term proposition to treat those people. And it does seem to have dramatic benefit, so it's wonderful, but, you know, the cost in the long term, mainly renal complications, and I suppose rash if you're younger than older, will be a problem for older people. I don't think the rash will be a factor, but
Yeah, so this is for me why it would be ideal to be able to have those angiogenesis inhibitors expressed directly in the tumour and not given systemically elsewhere, which is the approach that I've used before. Whether that's possible or not, we'll see.